Good morning. Today we will be looking at the critical appraisal of a randomized controlled trial which has used a win ratio analysis. Coming to the case scenario, we are looking at a 60-year-old male. He is a known case of diabetes and hypertension. He was admitted last month with symptoms of heart failure, namely worsening pedal edema and breathing difficulty. His echo done that time showed an ejection fraction of 40% with severe tricuspid regurgitation and a pulmonary artery pressure of 50 millimeters mercury. Normal is up to 20 millimeters. He is compliant to fluid restriction and has come to your OPD after about a month, and he is on optimal diuretics. He is, however, being told by his relative that there is a new procedure which can improve his clinical symptoms, and he is asking you regarding the same. So after a literature search, we find this article. This is a transcatheter repair for patients with tricuspid regurgitation. So coming to our questions, is the study design valid for a randomized controlled trial? So here we want to look at a PICOT statement. Coming to population, they have chosen patients more than or equal to 18 years of age with symptomatic severe tricuspid regurgitation. And what is severe, how they chose as severe, we look at in subsequent slides. Coming to intervention, intervention is a percutaneous tricuspid transcatheter edge-to-edge repair. And the control is usual care, mainly diuretics for symptomatic relief. The outcomes they have chosen as a hierarchical composite, which Sir has explained. First, they have looked at death from any cause or tricuspid valve surgery. So this is the first outcome. Subsequently, the second outcome that they look at is hospitalization for heart failure, and the third outcome is an improvement in the quality of life based on the Kansas City cardiomyopathy questionnaire. And the win, they have taken it as an increase of at least 15 points. The timeline was 1 year. So the study design was adequate. They have chosen, they have mentioned clearly regarding the population, the intervention, the comparators, and the outcomes. Coming to our inclusion criteria, patients who are more than or equal to 18 years of age with tricuspid regurgitation that was confirmed as severe by an independent echocardiographic laboratory. And with regards to symptoms, they should have an NYHA class 2, 3 or ambulatory class 4. They should have a pulmonary artery systolic pressure of less than 70. That means all patients had a right heart catheterization to determine the pulmonary artery pressure. And they should have been receiving stable guideline directed medical therapy for more than or equal to 30 days. They should not have any other cardiovascular conditions requiring an intervention like a severe AS or a mitral regurgitation or any other valvular pathologies. And they should have been deemed at intermediate or greater surgical risk by this team consisting of interventional cardiologists, surgeons, heart failure specialists who deem that they are at intermediate or greater surgical risk for a cardiac surgery, and hence will benefit from this percutaneous procedure. Looking at our exclusion criteria, they have not, it's not very strict. However, they have chosen everyone needs to have a right heart catheterization, and they should have a pulmonary artery pressure which is less than 70. So anyone who has a pulmonary artery pressure more than 70 would be excluded. Anyone who had a left ventricular ejection fraction of less than or equal to 20 would be excluded. So it's not very strict, and they have fairly included a lot of people, just that they needed to have this right heart catheterization to determine the pulmonary artery pressure before enrolling. Apart from that, all the other exclusion criteria were reasonable. They have excluded people with CVAs within 90 days, chronic dialysis patients with bleeding disorders, all were reasonable. Coming to our secondary outcomes, they've again taken secondary outcomes in a hierarchical order. So the first secondary outcome that they want to look at is freedom from major adverse events at 30 days. If this outcome is significant, then they will look at the second outcome, which is change in quality of life. If this result is significant, then they will look at the third, which is tricuspid regurgitation, reduction to moderate or less at 30 days after the procedure. So they go in a hierarchy from one secondary outcome to the other. And they have said that they will look at secondary outcomes only if the composite primary outcome turns out to be significant. Now, how were the patients, was the randomization done? Was it sufficient to eliminate systematic bias? This is a trial that was a multinational trial done in US, Canada and Europe. It was a multi-center trial and a randomized controlled trial. and they have randomized in a 1:1 ratio to receive this device, percutaneous tri-clip device or medical therapy. And they have stratified by site, and they have done blocks as well in 2, 4, 6. They have not specifically mentioned that allocation is concealed, but they have said that it's a central randomization service. So we can fairly assume that allocation has been concealed in this trial. Now, were all the participants who entered for the study accounted for at its conclusion? We look at it in the next slide. Intention to treat analysis has been done in this randomized controlled trial. Now, this is a study flow chart. So they have taken patients, as we already seen, patients who are symptomatic, have severe tricuspid regurgitation, and have been deemed to be at intermediate or greater risk for a tricuspid valve surgery. And if the patients meet these criteria, then they will go through the inclusion-exclusion criteria and then do an echocardiography where tricuspid severity is confirmed. Subsequent to this, they go through an eligibility committee which confirm that optimized medical therapy has been given, and they also look at the valve anatomy. So after this, then they look at ability to reduce the tricuspid regurgitation to moderate or less. This is based on different factors like baseline severity, the number of leaflet segments to be treated, the size of the anatomic leaflet gaps. So based on this, the team will decide whether the patient has a chance of being of the tricuspid regurgitation to reduce to moderate or less. Now after this, patients who are deemed likely to achieve at least a 1 grade reduction but not achieve moderate or less residual tricuspid regurgitation were assigned to a single arm cohort. So after this step, patients who they deemed could have some reduction in the tricuspid regurgitation but not to the extent that they need were assigned to another single arm cohort, and the rest of the patients were randomized in a 1:1 to receive either tri-clip device or medical therapy. Now coming to the Prisma diagram, they have looked at 1,573 patients, and they've mentioned the single arm cohort which we had seen in the previous one. They've also mentioned a roll-in cohort. Roll-in cohort is mainly the single arm cohort patients who had to undergo additional procedures. And then they've also mentioned 154 in screening process. Now why they've mentioned that is because they've taken the first 350 randomized population. So as we look at the statistical analysis, they deemed that 350 would be enough to achieve their outcomes. So the first 350 that they've randomized, they have taken. That's why the 154 are still in screening process. So the 350 that they've randomized to 175 to the procedure, 175 to control. And we can see that the total number of deaths in the procedure arm is 16 deaths and 7 lost to follow-up. The total number of deaths in the control arm is 14 deaths and 11 lost to follow-up. The study was also done during COVID, that is, it was done between 2019 to 21. So that also needs to be kept in mind. This is the device that they've used. They have also mentioned that halfway through the trial, there was a new generation of the device that was available. So they've switched to that, and that was incorporated into this trial. Was the study methodology sound? In this study, it was an open label study. It's not possible to blind patients to a procedure. But patients and investigators were not blinded, but they have blinded the outcome assessors, which is a good part of the study. Coming to baseline characteristics, were they similar at the start of the randomized controlled trial? We can look at the age of the patients. They were around 77 to 78. 56 and 53% were female. When we look at comparing the NYHA classes, comorbidities like dyslipidemia, hypertension, we can see that the NYHA class 3 or 4, number of patients who belong to this were approximately the same in both. There were a slightly higher number of patients who were dyslipidemic in the procedure arm as compared to the control arm. But apart from that, hypertension, diabetes, hospitalization for heart failure within 1 year prior to enrollment were all fairly matched. We will also look at the baseline echocardiographic data. A lot of the people had baseline ejection fractions of 59, so they had good ejection fractions. they mentioned that 94% of patients had functional etiology of tricuspid regurgitation. That means the tricuspid regurgitation was secondary to a left heart pathology or a left heart valvular pathology. And the severity of tricuspid regurgitation, around 51% in both groups, had torrential tricuspid regurgitation. So the severity was, they had severe tricuspid regurgitation, but they had fairly preserved left ventricular ejection fractions as well. Now, did both the study, did each study group receive the same level of care? What we want to look at is, did the treatment arm receive, apart from the intervention, any other significant things that could change their outcome in terms of more follow-ups? But we can see that both the arms were followed up at 1, 6 and 12 months. So as per the diagram that they've produced, they assessed symptoms, 6-minute walk test and quality of life measurements at 1, 6 and 12 months for both groups. So one arm did not receive additional care as compared to the other, as per what they have mentioned. So finally, before looking at the results, we look at the validity of the study. The study population has been well defined. They have defined the outcomes clearly, which is a hierarchical composite outcome. Randomization has been done, allocation concealment has been done, outcome assessors have been blinded. Sample size calculation we look in subsequent slides. They have done an intention to treat analysis, and baseline characteristics have been fairly well matched. So we can go ahead and look at the results of this study. In the subsequent slides, we look at whether the effects of intervention were reported comprehensively and whether confidence intervals have been reported. They have done both of these. Coming to the statistical analysis, as Sir has mentioned, they have used a Finkelstein-Schoenfeld method. And for this, to calculate the sample size, they have assumed these the following. These were the three outcomes. One is death or tricuspid valve surgery. The second was hospitalization for heart failure. And the third was improvement in the quality of life questionnaire. So the difference in death they've assumed as 15% in the procedure group and 20% in the control group. For hospitalization, 0.35 events per patient year in the procedure group and 0.5 in the control group. An improvement of at least 15 points on the quality of life questionnaire, which will occur in 45% in the intervention and 20% in the control group. Assuming these, they have calculated a sample size of 350 patients to have an 84% power to show superiority of the procedure to the control with the two-sided alpha of 0.05. They have also re-estimated the sample size after 150 patients and again confirmed that 350 is enough to show that it has benefit. The primary endpoint, the analysis was done using Finkelstein-Schoenfeld method and a win ratio. So win ratio they have calculated again by forming all possible pairs with each group. So the first they would look at if the patient, who had the first outcome, which is death or tricuspid valve surgery. If one group had faster than the other group, that group would lose. And then if they are tied, that means both the group patients did not have death or tricuspid valve surgery, they move to the next outcome, which is hospitalization for heart failure. If they were not hospitalized in both the groups, then they'll move to the third outcome, which is Kansas City cardiomyopathy questionnaire. And this was how the win ratio was calculated, and they've used SAS software for the analysis. So coming to the primary outcome, so the composite of these three outcomes that we looked at showed a win. Number of wins in the procedure group was 11,348, and the number of wins in the control group was 7,643, with a win ratio of 1.48 and a confidence interval of 1.06 to 2.13 with a significant p-value. Since the primary outcome was significant, they have gone ahead and looked at the secondary outcomes, which is percentage of patients with freedom from major adverse cardiovascular events. That will apply only to the intervention group. And that was also significant, so they've gone to the next, which is a change in Kansas City cardiomyopathy questionnaire. And since that showed an increase of around 12 points in the intervention group, while only a 0.6 in the control group. Since that was also significant, they've looked at tricuspid regurgitation of no greater than moderate severity at 30-day follow-up. Our inclusion criteria included severe tricuspid regurgitation. So around 87% of the patients in the intervention group had no greater than moderate severity at 30 days, while only 4.8 in the control group achieved that. The last one, change in 6 minutes, was not significant. Now let's look at the individual pairs that they've looked at. So number of pairs with all-cause mortality or tricuspid valve surgery in the control group was 2,884. That means this is a loss for the control group or a win for the procedure group. They have not mentioned the ties, but coming to the second, number of pairs with more heart failure hospitalization in the control group is 1,948. So these two are wins for the intervention group. Now coming to the third, improvement in the quality of life questionnaire is 6,560. We can see that a lot of the wins were contributed by the quality of life questionnaire as compared to the all-cause mortality and heart failure. If we look at just the all-cause mortality, however, we can see that the intervention group had more mortality. It was 8.8% in the intervention group and 7.7% in the control group. Even heart failure hospitalization was more in the intervention group than the control group. Major bleeding was also more in the intervention group. The per protocol analysis with the win ratio also showed a win ratio for the intervention group, however. Coming to subgroup analysis, we can see that the groups, they've compared patients with a more than or equal to 15-point improvement in Cancer City score and done a subgroup analysis. And the patients with whom this has shown clear benefit are patients who are less than 78 years of age, who did not have kidney disease and who had a fairly preserved baseline function, that is more than 50% ejection fraction with a more than 240 meter 6-minute walk distance. This was the group that it showed benefit in the procedure. This was just comparing the change in the quality of life according to severity. So patients who had moderate or less severity of tricuspid valve had a higher increase in the Kansas City cardiomyopathy score. And also based on the reduction of tricuspid regurgitation, patients who achieved a more than or equal to 2 grade reduction of tricuspid regurgitation had a higher increase in their quality of life. Now, do the benefits of the experimental intervention outweigh the harms and costs? This procedure, however, is not available routinely for all patients. It's being done in a trial phase. But the cost of a similar procedure will cost around 25 lakhs in our setting. And the all-cause mortality, we have seen it is more in the intervention group. Even though the win ratio, of which the quality of life contributed the most to, showed a win for the intervention group, the hard outcomes like all-cause mortality and hospitalization was more in the intervention group. Looking at adverse events were also more in the intervention group, 48% as compared to 41%. With increase, even the cardiac disorders were more in the intervention group, cardiac failure was more in the intervention group. Bleeding like hemorrhage was also more in the intervention group. Will the results help locally? I would say no, because even though the study participants looking at the baseline characteristics, except for diabetics, they have only 16 and 15% of diabetics. We see much more diabetes patients in our practice. Other baseline characteristics were fairly similar to the patients that we have. However, I would not advocate it as the outcomes are not important in terms of hard outcomes, and this study had few limitations. They have taken a mean change in quality of life. As I said, the quality of life has contributed more to the outcome, and the baseline population included people who had a good EF. We had seen the baseline characteristic that most patients had a good EF. They did not, even if you do the tricuspid valve surgery, if there is a significant left heart disease, it does not control for that left heart disease. And the sponsor, that was Abbott, participated in all the site selection, trial management, data collection, the analysis. So we can see that the experimental intervention is very expensive and all-cause mortality is more, even though the composite outcome is better. Coming to our case scenario, in this 60-year-old male who has come to you, to your OPD after 1 month of being on medications for heart failure, would you advise this intervention? I would not, based on this trial.
Excellent. Thank you.